This recording covers part 2 of acute pancreatitis. The priority collaborative problems for patients with acute pancreatitis include acute pain due to pancreatic inflammation and enzyme leakage, and weight loss due to inability to ingest food and absorb nutrients. Abdominal pain is the most common symptom of pancreatitis. The main focus of nursing care is aimed at controlling pain by interventions that decrease GI tract activity, thus decreasing pancreatic stimulation. Pain assessment to measure the effectiveness of these interventions is an essential part of nursing care. In terms of non-surgical management, mild pancreatitis requires hydration with IV fluids, pain control, and drug therapy. The healthcare team initially attempts to relieve pain with non-surgical interventions, which include fasting and rest, drug therapy, and comfort measures. Sometimes you'll hear it called bowel rest also. If the patient has a life-threatening complication or requires frequent assessment, he or she is admitted to the critical care unit for invasive hemodynamic monitoring. To rest the pancreas and reduce pancreatic secretions, withhold food and fluids, making the patient NPO during the acute period. The healthcare provider prescribes IV isotonic fluid administration to maintain hydration. IV replacement of calcium and magnesium may also be needed. Monitor and document I's and O's. Some patients have an indwelling urinary catheter to obtain accurate measurements. NG drainage and suction are reserved for more severely ill patients who have continuous vomiting or biliary obstruction. Gastric decompression using an NG tube prevents gastric juices from flowing into the duodenum. Because paralytic ileus is a common complication of acute pancreatitis, prolonged NG intubation may be necessary. Assess frequently for the return of peristalsis by asking the patient if he or she has passed flatus or had a stool. The return of bowel sounds is not reliable as an indicator of peristalsis return. Passage of flatus or a bowel movement is the most reliable indicator. To decrease pain, the primary drug used is an opioid, such as morphine or hydromorphone. Histamine receptor antagonists, such as famotidine, and proton pump inhibitors, such as omeprazole, help decrease gastric acid secretions. Antibiotics may be used, but they are indicated primarily for patients with acute necrotizing pancreatitis. Help the patient assume a side-lying position with the legs drawn up to the chest may decrease the abdominal pain of pancreatitis that they're experiencing. Sitting with the knees flexed towards the chest is also helpful. If the patient is NPO or has an NG tube, remind assistive nursing personnel to implement frequent oral and nares hygiene measures to keep the mucous membranes moist and free of inflammation or crusting. Observe for signs and symptoms of hypocalcemia by assessing for Volstex and Trousseau signs. For the patient with acute pancreatitis, monitor his or her respiratory status every 4 to 8 hours or more often as needed and provide oxygen to promote comfort and breathing. Respiratory complications such as pleural effusions increase patient discomfort. Fluid overload can be detected by assessing for weight gain, listening for crackles, and observing for dyspnea. Carefully monitor for signs of respiratory failure. If pancreatitis was caused by gallstones, an ERCP with a sphincterotomy or an opening of the sphincter of Oddi may be performed on an urgent or emergent basis. In regards to surgical management, surgical intervention for acute pancreatitis is usually not indicated. However, if an ERCP is not successful in removing gallstones, a laparoscopic cholecystectomy may be performed. Complications of pancreatitis, such as pancreatic pseudocyst and abscess, may also require surgical interventions. Laparoscopy may be done to drain an abscess or pseudocyst. For patients who are high surgical risk, pseudocysts or abscess can be treated by percutaneous drainage under CT guidance. In regards to promoting nutrition, the patient is maintained on NPO status in the early stages of pancreatitis. Antiemetics for nausea and vomiting are prescribed as needed. Patients who have severe pancreatitis and are unable to eat for 24 to 48 hours after illness onset may begin jejunal tube feeding unless paralytic ileus is present. Early nutrition intervention enhances immune system functioning and may prevent complications and worsening inflammation. Enteral feeding is preferred over TPN because it causes fewer episodes of glucose elevation and other complications associated with TPN. Be sure that the patient is weighed daily. When food is tolerated during the healing phase, the healthcare provider prescribes small, frequent, moderate to high carb, high protein, low fat meals. Food should be bland with little spice. GI stimulants such as caffeine containing foods like tea, coffee, cola, and chocolate, as well as alcohol, should be avoided. Monitor the patient beginning to resume oral food intake for nausea, vomiting, and diarrhea. If any of these symptoms occur, notify the healthcare provider. To boost caloric intake, commercial liquid nutritional preparations supplement the diet. Please review the care coordination and transition management section on your own.